Hello, good evening everyone. My name is Dr. Mustafa Kabbani and I'm very glad to be with you today. In the beginning, let me thank the creator, moderators, and admins group for inviting me and giving me the chance to be with you today. Alright, as choosing a topic is always a challenge, I dedicate this lecture to all the dental students and dentists who have difficulty locating canals during root canal treatment. So the topic of today's lecture is access cavity requirement for a successful root canal treatment. The access cavity is the first and the most important phase of the non-surgical root canal treatment. Having inadequate access cavity may lead to inadequate shaping and sealing of the root canal treatment. The key points of today's lecture will be: access cavity is the most important technical stage in root canal preparation. Common features in root canal anatomy. Basic principles for locating root canals and producing a good access cavity. So, in the coming few slides, I'll be talking about the importance of access cavity and how an inadequate access can lead to canals being left untreated, poorly disinfected, and may ultimately lead to the failure of the treatment. Alright, now let me start before talking about the access cavity to mention the rationale of root canal treatment itself. The root canal treatment is indicated whenever we have pulp or periapical tissue pathology. It's the treatment of choice in such cases. Alright, in this figure we can see the pulpal space morphology. The pulpal space can be divided into two parts: coronal pulp and radicular pulp. The coronal pulp can be also divided into three parts, which are pulp horn, which is the outermost layer of the coronal pulp; pulp chamber, the main area of the coronal pulp; and the orifices, which act as the gate to the root canal inside the radicular pulp. Now, the radicular pulp usually starts at the point below the orifice of the coronal pulp and ends at the apical foramen. The space in between these 2 points is referred as root canal, which can be accompanied with many lateral canals. So let's define the access cavity. Access cavity is an opening prepared in a tooth to gain entrance to the root canal system for the purpose of cleaning, shaping, and obturation. Access cavity is the first and the most important phase of non-surgical root canal treatment. As I mentioned earlier, having a proper, well-designed access cavity preparation will allow you to achieve good cleaning, shaping, and obturation of the root canal complex. As a result, we can consider the access cavity preparation as the most important phase of the root canal treatment. Alright, now let's talk about the objectives of access cavity preparation. Now, according to Cohen's, the following 6 points should be provided when we prepare a tooth. Number 1, we should remove all the caries and defective fillings. Number 2, we should conserve sound tooth structure of the tooth. Number 3, we should remove the pulp chamber completely. Number 4, we also have to remove all the coronal pulpal tissue, whether it's vital or necrotic. Number 5, we have to locate all root canal orifices. And finally, number 6, we should provide a straight line access to the apical foramen, or at least to the first curvature in case of double curved canals. On the other hand, Engel described the perfect coronal axis preparation as the one that can provide 3 points. Number 1, smooth, free, flowing taper channel from the orifice to the apex. Number 2, it should allow maximum cleaning and shaping of the entire length of the canal. And number 3, it should be very conservative with minimal loss of structural integrity of the prepared tooth. Okay, now let me talk about the 6 points that were listed by Cohen's in details. First of all, removing all caries and defective fillings. Why should we remove caries and defective fillings when we are doing or when we are preparing an access cavity? Actually, this is to eliminate mechanically as many bacteria as possible, which can leak into the prepared cavity and from there into the periapical area. Second point is conserving sound tooth structure. So, removal of excess enamel and dentin may weaken the tooth and increase the possibility of having a fracture, vertical root fracture, which may lead to extraction at the end, or even perforation. So, the key here is to remove dentin and enamel in strategic areas and to leave other areas intact. All right, now in the third and fourth point, Cohen stresses on complete removal of any coronal pulpal tissue and complete de-roofing of the pulp chamber. This is very important as leaving such pulpal tissue or incomplete de-roofing of the pulp chamber may lead to the failure of the root canal treatment due to the bacteria that can remain in these spaces. Also, leaving such tissue without being completely removed can cause discoloration of the teeth, which can be a big problem in case of anterior teeth. Point number 5 is locating all root canal orifices is very clear, I believe, as leaving any canal untreated will jeopardize the success of the root canal treatment. Lastly is to achieve a straight line access to the apical foramen. This is the most critical aspect of the access cavity preparation. In the ideal procedure, the instrument have to pass through the chamber without touching the walls of the cavity and through the straight part of the canal and deflected. This is very important. It will help us to have better visibility and it will also reduce the chance of the unfortunate incidents such as breakage of a file or even ledging the canal. So an adequate designed access preparation should allow the following. Number 1 should be very conservative with minimal weakening of the tooth. And number 2, it should prevent unfortunate accidents like perforations when locating canals or fracturing instruments when preparing them. All right, now what are the advantages of straight line access? First of all, improved instrument control. Number 2, minimizing instrument curvature and deflection. Number 3, better cleaning and shaping of the canal system. And lastly, less chance of undesirable internal alterations. So, straight line access will increase the operator ability to manipulate files in as many areas of the canals as possible without changing the internal canal anatomy. It will also help in better shaping and the cleaning of the canal system with less chance of ledging, zipping, or transportations. All right, now let's move on to the access cavity preparation principles. In the beginning, I will list the 4 principles, 4 points, and then I will start explaining each of them. So number 1 is outline form, number 2 convenience form, number 3 removal of remaining carious dentin and defective restorations, and lastly number 4 toilet of the cavity. All right, now let's move on to the first principle, principle number 1, which is the outline form. To achieve optimal preparation, 3 factors of internal anatomy must be considered. First of all, the size of pulp chamber. This is number 1. In younger patients, the size of pulp chamber will be bigger, while it will be more limited in older patients. Number 2, uh, the shape of pulp chamber, for example, the molars will have triangular or trapezoidal pulp chamber. The premolar will have oval or ovoid pulp chamber. Anterior teeth will have triangular pulp chamber. And finally, number 3, the number of individual root canals, their curvature, and their position. We should consider all this when we outlining the form of the cavity. For example, in molar we will have 3 or 4 canals. In premolar we will have uh, 2 or 1 canal. Anterior will have mostly 1 canal. So we have to consider all this when we are outlining the cavity. So here, as we can see, the shape of different teeth. Anterior will be triangular, premolar will be oval or ovoid, molars will be triangular or trapezoidal in case of upper molar. And we can see how every tooth will have different number or curvature of roots. Uh, Molar will have more roots when we compare it to the anterior, for example. Now, the second principle is the convenience form. The convenience form makes more convenient and accurate preparation and filling of the root canal. 4 important benefits are gained through the convenience form modification. First of all, better visibility by having unobstructed access to the canal orifice. Number 2, direct access to the apical foramen will help in reducing the chance of having unfortunate incidents such as fractures, ledges, or perforation. Number 3, complete authority over the enlarging instrument, so we will not have ledges. And finally, cavity expansion to accommodate filling techniques. Again, the third principle will be stressing on the complete removal of remaining carious dentin and defective restoration. And here are the reasons for removing caries and defective restorations. First of all, as we mentioned before, elimination of bacteria, elimination of discolored tooth structure, and finally, elimination of possibility of coronal leakage. All right, now let's move to the fourth and the last principle, which is toilet of the access opening. Well, in this principle, we have to know that all of the caries, debris, pulpal tissue, and necrotic materials must be removed from the chamber before entering or starting the preparation of the radicular part of the canal. Otherwise, these elements may be carried into the canal and it may act as obstructions during root canal enlargement. The soft debris carried from the chamber might increase the bacterial population inside the canal, and the coronal debris may also stain the crowns, especially of the anterior teeth. Alright, now let's move on to the guidelines for preparation of access cavity. First of all, the first principle is visualization of the likely internal anatomy. This can be done by using X-ray or a probe. With an X-ray, we can take diagnostic radiographs that can help the clinician to estimate the position of the pulp chamber, the degree of chamber calcification, the number of roots and canals, and also to determine the approximate canal length. Alright, now the second guideline is evaluation of the cemento-enamel junction and the occlusal anatomies. Now, the cemento-enamel junction is considered as the most important anatomic landmark which help clinicians to determine the number and location of orifices on the chamber floor. Now, the third guideline is to prepare the access cavity through the lingual and occlusal surfaces. Lingual surfaces will be in the anterior teeth, while the occlusal surfaces should be prepared in the posterior teeth. Alright, now the following guidelines number 4, 5, 6, and 7. Number 4, as we mentioned before, removal of all defective respirations and caries. This is because we don't want bacteria to leak into the root canal, inside the root canal. Guideline number 5, we should always have straight line access to the apical foramen or to the initial or the first canal curvature. Guideline number 6, we have to locate all the root canal orifices so we don't end with untreated canals, which may lead to the failure of the treatment. And finally, guideline number 7, which is tapering of the cavity wall of the access cavity. This is to provide an adequate space for temporary filling that should provide an adequate coronal seal between visits. Alright, now the coming few slides are very important. I'll be talking about Krasner and Ranko laws of pulp chamber anatomy. These laws will help you to prevent any perforation when performing an access cavity and also will help you in getting mental picture of the location of the pulp canals. Alright, now Paul Krasner and Henry J. Ranko have given guidelines or laws which will help any practicing dentist to obtain proper access to opening and to locate the pulp chamber easily. They mention certain important points by pointing out the relationships of pulp chamber to the clinical crown and to the pulp chamber floor. So, what are these laws? They are 9 in number. The first one is law of centrality, which states that the floor of the pulp chamber is always located in the center of the tooth at the level of cemento-enamel junction. This law helps you to determine the depth to which you can go without causing any perforation. Here you can use an intraoral periapical X-ray or just place the burr against the tooth and measure it against the burr length to have an idea of the depth to which you can extend in search of the pulp orifice without causing any perforation. The second law is the law of concentricity, which states that the walls of pulp chamber are always concentric, which means that they are around the pulp chamber following its shape to the external surface of the tooth at the level of cemento-enamel junction. The third law is the law of cemento-enamel junction, CEJ. It should be used as a landmark to locate the pulp chamber as it's always repeatable and consistent in its position in any tooth. The next law is the law of color change. This is a very important law, especially when you are doing the treatment under magnification. In this law, we have to know that the pulp chamber floor is always darker in color than the surrounding vertical walls. You can see this in the photo. You can see how the pulp chamber is much darker in color, almost brown, when it's compared to the vertical surrounding walls, which are much lighter. The coming two laws are the law of symmetry 1 and law of symmetry 2. The law of symmetry 1 states that except for maxillary molars, the orifices of the canals are equidistant from a line drawn in a mesiodistal direction through the pulp chamber. So let's say that the mesiobuccal canal was 2 millimeter away from a line drawn in a mesiodistal direction through the center of the pulp chamber floor. Then I should expect to find the mesolingual canal at the same level of the mesiobuccal canal, and it should be also 2 millimeter away from the line drawn in the mesiodistal direction through the center of the pulp chamber floor in the lingual site. Now, the second law of symmetry states that except for the maxillary molars, the orifices of the canals lie on a line perpendicular to a line drawn in the mesiodistal direction across the center of the floor of the pulp chamber. Alright, so this is very useful in retreatment cases. So whenever I'm doing a retreatment case and I found that the previous dentist treated only, let's say, one distal canal, and that distal canal is located more to the more to the buccal or more to the lingual. At that time, I should expect a second canal. I have a video that can show you exactly the application of this law. I guess I'm going to play that video after this part of this lecture. Alright, now let's move on to the laws of orifice location. They are 3 in total. The first one says that the orifices of the root canals are always located at the junction of the walls and the floor. We can see this in figure B. Now the last orifice location law is that the canals are always located at the end of the developmental fusion lines. We can see that there is a dark Y-shaped line connecting between the canal orifices. This or these lines are called developmental fusion lines, and we should always expect to find our canal orifices at the end of these lines. While the second law of orifice location says that the orifices of the root canals are always located at the angles in the floor-wall junction. We can see this in figure A. The last law of orifice location is that the orifices of the root canals are always located at the terminus or at the end of the roots or developmental fusion lines. So we can see in the two photos the Y-shaped dark line. These are named as developmental fusion lines, and we can see how the canals are located at the end of these lines. So these lines can help us to locate our orifices. In this video, we can see how I search for a suspected mesiolingual canal. I had one canal in the distal. That canal was closer to the buccal wall, so I suspected another canal closer to the lingual side. Enjoy the video. Using ultrasonics in searching for suspected canal is very important to avoid any possible perforation and to keep the work more conservative. Here I found a catch. Alright, now let's move on to talk about the access cavity preparation of different teeth, upper and lower. So in the beginning, we will start with the maxillary, central, and lateral incisors. Alright, now the shape of the access cavity of both maxillary central and maxillary lateral incisors will have the shape of rounded triangle, with its base toward the incisal aspect. The width of the base will be determined by the distance between the mesial and distal pulp horns. Now I'm going to talk about some facts about the central and lateral maxillary incisors. It's very common to have lateral canals in both maxillary central and lateral incisors. The lateral canal in lateral incisors usually huge in size, and sometimes the root canal in lateral incisor ends with an apical delta. Now the next tooth is maxillary canine. Usually, the access cavity of the maxillary canine is oval in shape because there is no mesial and distal pulp horns. Now, the access cavity for maxillary first premolar is usually oval in shape. It's wide buccolingually, narrow mesiodistally, and centered mesiodistally between the cusp tips. Sometimes maxillary premolar has three canals. In this case, the access cavity will turn from oval in shape to triangle in shape, and the base of the triangle will be toward the buccal side. We can see this in the middle photo because in these cases the premolar will have two buccal canals and one palatal canal. In this diagrammatic representation, we can see the supplemental canal configuration of the maxillary premolars. So we can see one canal, two canal, three canal, four canal, five canal. Premolars are always tricky. They are never easy teeth to be treated. Alright, now let's move on to the maxillary molars. Now, let me talk in the beginning about the maxillary first molar, which is the most complex tooth because it's almost always has four canals, and the access cavity will have the rhomboid shape, with the corners corresponding to the four orifices. During the preparation of the access cavity, we shouldn't extend to the mesial marginal ridge mesially, while during the preparation in the distal side, we can invade the mesial portion of the oblique ridge, but we should never penetrate through the ridge. Now, on the other hand, the maxillary second molar will have different anatomic variation. Sometimes it comes as a single canal, other times two canals, maybe three canals, and sometimes we have four distinct canals. The shape of the access cavity will be rhomboid when it's four canals, exactly like the first maxillary molar, while it will have a rounded triangle shape when it's three canals only, or oval in shape when it's two canals or single canal. Alright, now let's move on to the mandibular teeth. We will start with the access cavity of both mandibular central and lateral incisors. These canals can have a single canal or sometimes two canals, which is very common. The shape of the access cavity will be triangle or oval, and that will depend on the prominence of the mesial and distal pulp horns. Now, sometimes when we have a limited access, this sometimes will impede the instrument from getting into the lingual canal. So, removal of the coronal obstacle is required to have an adequate access cavity so the file can enter the lingual canal easily. Now, the next tooth is the mandibular canine. The shape of the access cavity is very similar to that of the maxillary canine, which is oval in shape. But we have to note that sometimes the mandibular canine can come with an extra apical canal, and sometimes it splits into two canals but then they return to join and exit apically as one canal. This is also common. Alright, now let's move on to the mandibular first and second premolars. These teeth are very tricky. They can be single canal or double canals, and sometimes they divide at the mid third, at the mid root, to and branch to into different number of canals, one, two, three, four. Sometimes they rejoin at the apical third and they exit at a single portal of exit, and sometimes they exit at different portal of exit. So they are very tricky, and the usual access cavity is oval in shape, which will be a little bit wider mesiodistally when we compare it to the axis of the maxillary premolars. Right now, let's move to the mandibular molars, mandibular first and second molars. Okay, now regarding the mandibular first molar, the access cavity shape will be sometimes triangle, other times trapezoidal, and other times will be rhomboidal, while the axis cavity of the second molar will be a bit more triangular and less rhomboid. All right. Sometimes we have a lot of variation for these two teeth. So for the first molar, it can have three canals, four canals, five canals, or even six canals, like the X-ray below. Here is a retreatment case that I've done almost 3 years ago. When the patient came to the clinic, uh, he had swelling and pain, and on X-ray, I was able to detect four obturated canals. But when I tried to retrieve the tooth, I found two other canals, so in total we had six canals. Also, this tooth can uh, have five canals, like three canals in the mesial, two canal in the distal. I retreated the other teeth that had two canals in the mesial, three canals in the distal, so it can vary a lot. Also, the lower second molar can also come as two canals, and at that time the access cavity will be rectangular, and it will be wide mesiodistally and narrow buccolingually. I didn't have the chance to treat one canal second molar, lower second molar, but I know a lot of people who post such cases in Facebook and Instagram, so it's kind of rare, but if you are lucky, you will you will have such a case. We should also mention that there is a huge chance to have a three-rooted mandibular first molar in cases like radix entomolaris or radix paramolaris. Finally, we reached the last part of this presentation, the potential errors during access cavity preparation. The first one is overextension. Overextension may be the result of uh, improper burr angulation, or failure to recognize the lingual inclination of the tooth. This will result in weakening of the coronal tooth structure, which may lead to coronal fracture. Also, we could have inadequate access or opening. This may lead to fracture of a burr or a file, in addition to coronal discoloration, errors during obturation, root perforation, ledging of the canal, apical transportation. All these possibilities can occur due to inadequate access. Also, we can have misdirection, which may lead to perforation and labial perforation. Labial perforation that can be caused by failure to extend the preparation to the incisal edge before the burr shaft entered the access cavity. Also, we may have perforation at forcation area of multi-rooted teeth, accidental obturation of canal orifices with debris, weakening of tooth structure as we mentioned before, failure to reach the pulp chamber. This is also possible due to misdirection. And finally, we may access the wrong tooth. This is very possible, especially when you are in rush and you just want to finish the treatments because you have other patients waiting. So we always have to mark the tooth that we are going to work on, especially when we have identical crowns of adjacent teeth, and that should be done before placing the rubber dam. At the end, I would like to thank the moderators and the members of a group for having me today. And I wish I gave you some tricks that can be helpful in your daily endodontic practice. In case you have any questions or inquiries, you can always contact me. These are my two Facebook accounts and my Instagram account. You can always contact me and send me your questions if you have any. And I wish you the best in your future root canal treatment. Have a good night. Regards from Dubai.